Today on Global Health Frontiers.
We have a country of over 1 billion people. Just under half of those people do not use a toilet.
Pooja is concerned about why her children are not growing.
The stunting problem in India represents the largest loss of human potential in any country at any time in history.
We're in Lyme, Connecticut. This is where it all started. I felt like I was spinning out of control, shaking.
For the last 2 decades or so, we have seen a general increase in the number of tick-associated diseases.
Guatemala is one of the countries in Latin America with the worst maternal mortality ratio.
Our hope is that traditional birth attendants are going to refer pregnant women during labor to clinics.
It is a defining challenge of our time. Bringing modern medicine to hundreds of millions suffering from preventable and treatable diseases and conditions of poverty. Eliminating infections in many areas and tracking the sources of deadly global pandemics. With new advances in resources, science, and skills, pioneers on the frontiers of global health offer hope for healthy, productive lives. These are their stories.
Global Health Frontiers is made possible by support from the John Moores family.
Stunted growth caused by lack of nutrition is a common condition among children in many areas of Africa and Asia. Its effects typically become permanent, leaving its victims with diminished height and weight, at greater risk of illness and premature death, and reduced mental development. Stunting has always been related to inadequate feeding practices and poor maternal nutrition.
The children of women who are stunted are more likely to be at risk for chronic diseases. They're also likely, if they are daughters, to produce children of their own that are stunted.
But studies now show that stunting can be caused by lack of basic sanitation. In these studies, comparing children in India to those in Africa, stunting is more prevalent among Indian children, even though they are generally better fed, and poor sanitation is blamed for the difference. In India, there is growing recognition that protecting children from stunting and from a wide range of infectious diseases will depend on major improvements in sanitation nationwide.
The name of the slum is Indra Kalyan Vihar. You have to be careful here. It is situated in southern Delhi. As you see, the drains are open. Generally, people here come from neighboring states looking for better job opportunities and get settled in these congested clusters. My name is Shamaila Khalil, and I'm working as a program assistant with Save the Children India. The water from the drains is clearly getting seeped into the pipelines, and they would be using this water for drinking. The water in the slums is not available regularly, and so whenever they have the water supply in the slums, it's like a celebration, it's like an event. At the same time, these children are given the assignment to basically fetch water from the nearest source and collect it and store it here. The water that they are using for the household activities is also contaminated. They are not even aware of this contamination. The average family size is 5 to 6 members live in these small 8x8 rooms. They are living in a small space, and so there is no space left for the toilets. As a result, families, they go to the community toilets that are there in the slums. खुश हैं आप उससे?
जो है वही उसी में ले जाएंगे.
Her name is Saroj, and she has been living here since she was 7 years old. She is using the community toilet complex that is here in the area, but she is not very happy with the conditions in which the community toilet is, but she has no other option but to use it. But at the same time, they go for open defecation.
We have a country of over 1 billion people, and just under half of those people do not use a toilet. 595 million people are going outside every day to defecate. And so all that poo in the environment is affecting not only the health of children, but the health of everybody in the country. This is something that's gone on for generations. It's entrenched in caste, in gender, in social status. A child in India learns how to squat, learns how to go outside and open defecate. A child's hands go into feces, feces go into mouth, and we have the whole process of ingesting excreta. Once that's in the gut, a child cannot really tolerate infections and keeping a healthy life.
So this drain behind us, it runs right in the middle of the slum. A lot of people residing here, they throw the garbage into this drain. As a result, the drain, this big drain also gets blocked. And it is not very regularly cleaned. We also see that in the houses that are on the either sides of the drain, they have these temporary toilets in their houses. The fecal matter comes directly into this big drain.
Growing up in an environment where fecal matter is more accessible than it really should be means that there's a greater propensity for what is called environmental enteropathy. So basically a disruption of gut function, which then results in stunting. About 40% of India's children under the age of 5 are stunted, which means they haven't reached the appropriate height for their specific age, either by age 2 or by age 5. And this has long-term consequences for their ability to go to school, their ability to hold down a job. There is a segment of government that believes that perhaps the stunting problem in India is not really an important one because maybe Indian children are genetically prone to be shorter than other children. But that's simply not true. Children of Indian origin growing up in parts of the world where there is access to sanitation and to good nutrition are able to grow to the same extent as Caucasian children or African children. So there is simply no excuse for ignoring the problem of stunting in India.
The community health volunteer came across this case. The baby has been constantly underweight and malnourished. The mother was not sure that the water that she was giving to the child was safe or not.
We have to make them aware of that. Children up to the age of 1 year at least 1 year, should be given boiled water.
Exposure to fecal matter in the intestine causes an inflammation, and the surface area that is available for nutrient absorption is reduced, which requires, the system to fight this chronic inflammation rather than to grow.
The mother was not even aware that her child is not well. Mind your head.
पूजा, आपका उम्र कितना है?
मेरा
This mother's name is Pooja, and she has been living in this slum for the past 10 years now. She has 4 children. The youngest happens to be 19 months old and is severely underweight. So Pooja is concerned about why her children are not growing, despite of the fact that she has been taking proper care and she has been giving good food to them. I explained it to Pooja that the energy that they are obtaining from the food that they are eating is being utilized only to fight the infection, and they are left with no energy to be utilized for their growth.
The stunting problem in India represents the largest loss of human potential in any country at any time in history. Now that sounds like a bold statement, but the fact is that more children are born in India each year than have ever been born in any country. 27 million children, that's larger than the largest birth cohorts in China. And if 40% of that 27 million children are failing to reach their full growth potential, that's a staggering loss that has global implications. It's not just an India problem, it's really a world problem.
We're heading out of Delhi to a village somewhere southeast of the city. My name is Sangeeta Vyas, and I'm the Managing Director for Sanitation at RICE, the Research Institute for Compassionate Economics. At RICE, we focus on doing research and policy advocacy on things that affect child health. 70% of Indian households are living in villages. The area that we're going to, people live more centrally, all collected together, and then their plots of land are outside of the actual village. So population density can be quite high, which is important for open defecation. About 350 households live in this village, and there are people from different caste groups. This is Nick Hill, and he works with our organization RICE. We're in the lower caste area of the village, and we learned from him that some of them were traditionally the ones who've had to do the work of manual scavenging and manually cleaning feces. Castes are hereditary, and it sort of defines what your occupation or your job in society is going to be. And so you're born into a caste, and particular jobs carry with them elements of purity or pollution. Namaste. He was just telling us a little bit about his family. There are 4 people in his family. They've been living here forever. He has 2 sons, and they do farm work. We were asking him a little bit about his house, and he told us that they do not have a toilet. They all go defecate in the open in the fields. A lot of people in the higher caste part of the village, a lot of those people had latrines. So we asked him whether it would be good or bad to build a latrine near his house, and he said, nowadays, people build latrines in their homes, but then he started talking about the government program. The elected village leader has built these government latrines for people, but he says he thinks that they've sort of cut corners in the construction and the pit is smaller than what it's supposed to be. There's a government latrine next door. He says the pit is about 2.5 feet deep. It definitely looks like it's not used regularly. In fact, here we have gobar, which is used for cooking fuel, and it's very common for latrines like this to only be used in an emergency. People really don't want to use simple latrines because it requires being periodically emptied. We asked him, how they would clean it out if it got filled up, and he responded that who would come to clean it. The bottom says, Rukdam Swachhata ki or.
A step towards cleanliness.
That was really a fun wedding party that we got to be a part of. We've conducted 2 different types of studies on people's attitudes and beliefs around latrines and latrine use. What we've learned is that it has a lot to do with caste and a lot to do with India's unique history of untouchability. So what that means today is that cleaning up human feces is considered to be very socially degrading and is associated with extreme social exclusion because it means that you're impure and it means that you must be from a low caste. So we were just asking him, in which one are people healthier? A village in which everyone goes in the open or a village in which everyone uses a latrine? And he told us that a village in which everyone goes outside in the jungle, those people are healthier. I'm asking them where people normally go to defecate in the open.
Thinking about sanitation in this country is something that people are blind to. People think it's nothing to do with them. Everybody in India needs to change their behaviours and their thinking around sanitation. There's no magic bullet answer, but it's finding the trigger in communities, whether it be dignity, pride, aspiration, to actually get people readily accepting the change from open defecation to toilet use.
To reduce the open defecation, we need to have access to toilet facility. My name is Sanjeev Kumar Behera. I am the program coordinator for Save the Children India. These are the showers. This is the toilet. This particular locality, people were using as the place for open defecation. We have all the messages here, how to clean their hand. When we started, there is a demand of around 300 flushing per day. After 2-3 months, we realized around 800-900 people has come up every day. Now we have started constructing the second set of toilet. Most of the toilet complex is not properly functional due to lack of timely maintenance. This is the water treatment plant. Each drop of water being monitored. People have to come with the card and get water. For using the toilet facility, people have to pay 1 rupee, which is around 2 cents in American currency. This is a toilet complex which is being managed by the community itself. These women, they have come forward, the community group who are managing the toilet. They have to use it. They are taking ownership.
This has to be an ongoing process for behavior change, for people to continue to use these toilets, for this to be the norm. It sounds like a big task, but it's been done. Bangladesh has managed to do it. Nepal has managed to do it. So this is a solvable challenge.
Sanitation in India is not simply about constructing toilets. The bigger issue to solve is actually motivating a household, a community, a society to want an open defecation-free India. So we have to look at ourselves as members of society and realise that we have a role to play.
The term emerging diseases is usually linked to dense tropical forests in distant lands. But diseases are also emerging in the most developed parts of the world. Some resulting from the bites of tiny ticks.
I felt like I was spinning out of control, shaking. My brain felt like it was just shaking.
I saw the rash, kept getting bigger.
I was just perspiring like I was under a waterfall.
In hysteria, I said to the woman, "Oh my God, I have Lyme disease."
Ticks are second only to mosquitoes as vectors of human infectious diseases.
For the last 2 decades or so, we have seen a general increase in the number of tick-associated diseases.
In the United States, serious trouble with ticks began about 40 years ago in Lyme, Connecticut.
We're presently in South Central Connecticut, where there's an epidemic of Lyme disease. My name is Tony DiNicola, the president of White Buffalo Incorporated. We're a nonprofit organization that specializes in wildlife research and management. And this site in particular has the highest recorded tick densities ever. Our focus today is to capture some animals on site and administer large cattle ear tags that'll help us identify those animals in the future and also serve as a means to estimate the local population. It's good. We're a little early. It's fine. We'll do some of the inner roads where they're starting to move, and maybe we'll get an opportunity. The only ticks I remember as a child were dog ticks, the large ticks that were often found in open grassy areas. So they're much more visible and detectable, and never really heard of Lyme disease growing up. There's two primary components to the zoonotic cycle with Lyme disease. You have the deer abundance issue that allows for ticks to reproduce, and you have small rodents that allow for the transmission of disease. Mice are probably easier to address with treatments on a local level, but on a landscape level, really the management of local deer populations is the only option. We've got one coming up on the left. We use these small projectiles, and we attach a small microtransmitter to the back. And that allows us to find the deer even in the dark.
As you just control her head. Ready?
The reason we're out here this evening is to try to get tags placed in as many females' ears as possible. The greater percentage of your population that have ear tags, the more accurate your population estimate is. She's actually 2.5 years old and hasn't bred. And then as soon as I reverse, Vicky will pull the mask off and we'll skedaddle out of here. In our infinite wisdom, we've created perfect deer habitat. We like lawns, we plant shrubbery. Many people say that we've displaced deer through development when in fact we've enhanced the habitat to a point where the populations have escalated. It affects everyone. It affects the ecology of the forest, it affects our ability to drive safely on the roads, and it's dramatically increased our risk of Lyme disease. All the data we have today show it to be very clear that tick abundance and deer abundance are closely tied together. It's surely not a coincidence.
Off we go. Back to where we came.
I'm Rick Ostfeld, senior scientist at the Carey Institute. I study the interactions between organisms in nature. So I just dragged this cloth for about 20 yards or so, and we came up with 4 ticks, 4 adult black-legged ticks. And I would say that's a fairly typical number for this particular type of habitat. Ticks really like nice, protected, shaded, moist, cooler conditions in which to seek a host or quest. I think the evidence that the risk of human exposure to Lyme or human incidence rates with Lyme disease are linked to deer is very weak. Reducing the number of deer more often than not fails to substantially reduce the number of ticks and the incidence of Lyme disease in the human population. We use the forest as a lab. You could think of a plot of the woods here as a test tube.
We're walking through some tick habitat here.
We're able to do experiments, vaccinate white-footed mice.
So I only found one tick here at the tip of her ear.
We know these ticks live in very complex environments. I mean, look around us. These white-footed mice that are probably the most abundant vertebrate in most of our forests here in the Northeast are a very high-quality host for the immature stages in the tick life cycle, the larvae and the nymphs. So the more mice there are, the better the ticks do, and the more often they get infected with these tick-borne pathogens that cause disease in humans.
And that's that.
What we found is that when you have extensive undisturbed forest, the abundance of infected ticks tends to be fairly low. If you chop up the forest into little bits, then the abundance of infected ticks and therefore Lyme disease risk goes up. In fact, the more trashed, chopped up, fragmented the forest, the better the mice do, partly because their predators tend to disappear. Then what you always have left, you always get white-footed mice.
The mouse is what we call the reservoir for Lyme disease. It's the source of the infection. Ticks get it from the mice. My name is Kirby Stafford, and I have been spending the last 28 years examining a number of different ways to control the black-legged tick, which transmits causal agents for Lyme disease. We're part of the Tick Project.
Oh!
You might be able to see these tiny, tiny little ticks on the ears here.
Now they're just trapping the mice and, look at how many ticks are on them, take a blood sample so we can test them. We're in the third year of an integrated tick management program funded by the Centers for Disease Control and Prevention.
Oh, well, I'm glad to see somebody's on top of it. Thanks a lot.
You're welcome. This is the nymphal stage. This stage of the tick is what most people get Lyme disease from.
I was trimming some of the bushes around the yard here, and my wife, about an hour later, said, "What's that spot on your side?" And I said, "It's a tick." Removed it. Week later, all the symptoms attacked me.
I noticed a tick and was able to get it off, but then I noticed that the swelling increased.
It's a little tick will crawl around, and you can't see it, and you can't feel it, so it could be anywhere.
This disease is primarily a residential disease. We believe about 3/4 of all the cases are acquired right in people's backyards.
We see quite a bit of Lyme disease. It's become much more common, in particular 15 years that I've been here. My name is Dr. Paul Nee. I'm an infectious disease specialist here at Danbury Hospital in the western part of Connecticut. And how are you feeling generally overall?
Overall, I feel good, but I'm still awfully weak.
After the tick bite, majority of patients may develop a skin rash. The rash can be the bullseye. After a few weeks, those patients may present with a facial palsy. Maybe a few weeks later may have a heart condition, heart block, and then many months later may develop a swollen, painful joint. Patients may present with one of these symptoms or many of these symptoms.
And I started out with a pain in the back of my neck, and it went right straight over my ear and down the side of my face. The first doctor I went to told me I had shingles. And they sent me here, and he came in and he says, "You ain't got shingles." He says, "You have Lyme disease." Now I can eat.
Now you can eat, yep.
Thank you.
We're in Lyme, Connecticut. This is where it all started, back in the 70s. I'm Robin Curran, and I have Lyme disease. I've actually had it twice now, but it's affected my whole life. Pretty tough deal. It was the fight of my life.
And I'm her sister. My name is Sue Balestrini.
This is the dock that we used to hang out on when we were little. We played in the woods from sunup to sundown back then, and we're just pulling ticks off us. That's the tree swing that we used to swing off, and if you can see, it's really pretty wooded in there. We had no way of knowing or had no idea what these little things were going to do to us.
I would say 7 or 8 family members have been affected by Lyme disease.
Yeah. We were among the first kids to get it. I would lay in bed screaming as a child. I remember that. My legs hurt so bad, and I would just cry and cry and cry. And my mom would take me to the doctor, and they just kept saying, it's growing pains. And I got bit later in life, and that's when, really went downhill. It got to the point where, I couldn't even walk to the bathroom. I crawled. Now, I'm not a sedentary person, and to have to lay in bed for 7 years of my life.
You were thin and active and physical.
This is me scuba diving in Australia in the Great Barrier Reef, kayaking in Hawaii. It's my son and I skiing. That's the mom he remembered, and all of a sudden, he sees this person laying in bed all the time. I don't know that I'll ever be the same, but I'm fighting and I'm getting there, right? I'm getting there.
From a clinical standpoint, I think some of the misconceptions of Lyme disease is that, it's not treatable. Well, it is treatable. It's a bacterial infection. It's treated with antibiotics. And catching it early, obviously, like any disease, is the best. And there's no long-lasting immunity. You can get it again. So I've known people that are getting Lyme disease every summer as a normal ritual, almost. So mainly where the ticks on this property would be associated with the stone wall and the little forested area here along the edge. Our New England stone walls are essentially mouse hotels. A lot of our research is focused on a number of different approaches to manage or control the black-legged tick. Application of pesticides, exclusion of deer, treatment of deer, treating the mice with what we call host-targeted acaricides. This is the rodent bait box. This is the vaccine bait. So it's just a special formulated pellet, and the vaccine is actually coated on the outside of each one of these pellets. So by giving the mice the vaccine, if we can eliminate the infection in the mice, we should be able to reduce the prevalence of infection in the ticks around people's homes.
Future scientists on our hands. No.
We just put the traps out yesterday. They stay out overnight, and we collect them today.
Yeah, so that one's empty too.
We've generally been getting about a 20% capture rate for the mice.
Uh-oh, this one feels promising.
But that's a fat guy.
That's a fat
We get a
mouse.
lot of peanut butter.
Hello.
Today, it seems like we're getting closer to about 50%. The more mice, the more data.
Cool, huh? See the little ticks on there, guys?
I know.
Right? Think you could see that if it was on you?
Maybe.
I grew up in Alabama, and there are tons of ticks there, but they don't carry anything that you really have to be too worried about. Woo, awesome. We have 3 boys, and they love nothing more than playing outside, so it's kind of unfortunate that it's a fact of life here in New England. It's something we really wish we didn't have to think about, but something we've got to pay good attention to.
That's pretty much as high as I can go.
I'm pretty lucky that my kids are fair complected and light hairs, so it's pretty easy to spot them, but we've missed a couple, and 2 of our 3 kids have actually contracted early stage Lyme, so we've been through the rounds of a few weeks worth of antibiotics to take care of that. So what happened when the tick bit you that time?
Oh, he got a bullseye, and we had to get some special medicine.
When it comes to actual tick control strategies, there's certain landscape things you can do. Their swing set is actually out in the middle of the yard where your risk for Lyme disease is your absolute lowest. When you look at open lawns, that's not where the ticks are. They require high humidity, and that's really basically where their hosts are, the mice and the chipmunks and things like that. They're in those woodland edges. So that is your higher risk zone.
We do some spraying, like just using repellents on them. We'd rather not use too many chemicals on the kids if we don't have to. Really, it's just at the end of the night, just doing really thorough checks. Every kid is pretty accustomed to getting a full body tick check after they've been outside. I do want my kids to be outside as much as possible, and there's always, the fear that there's a tick we're going to miss, and there's going to be some, longer term effects that we're not sure about.
These are red oak acorns. We're standing under a red oak tree that happens to be producing thousands and thousands of acorns this year. So the mice and chipmunks go around gathering these things and they store them all winter long. And so the summer after one of these great acorn years that we're seeing right now, the woods are just crawling with mice. So that's great for things like owls, foxes, if you like to eat mice. But it turns out it's also great for ticks.
This is the larval tick. They would be extremely hard to see on a person. We're vaccinating them against Borrelia burgdorferi, which causes Lyme disease.
If we can use the abundance of mice as a leading indicator of Lyme disease risk a year in advance, then we can mobilize forces to try to reduce the tick abundance or to try to inform people about taking extra precautions to try to protect themselves.
Naturally occurring fungus.
And I guess one other point is that even though we're not very good at controlling mouse populations, they're natural predators that are. And so if we can manage our landscapes around here to maintain a healthy guild of predators, that means foxes, owls, hawks, weasels, creatures like that, then they'll do it for us. There seems little question now that that would help protect our health as a consequence of regulating mice.
Every 2 minutes, a woman dies from complications related to pregnancy and childbirth. An estimated 300,000 deaths every year. The vast majority in developing countries, where most women's lives are restricted by illiteracy, poor education, and poverty.
Women don't recognize the risk symptoms in their bodies, or if they do, maybe they don't pay too much attention and say that they will go away.
Most of these deaths are preventable.
Hola! Hola, bonita!
But fewer than half of all births in developing countries take place with the help of a skilled birth attendant. With the right tools and resources, conditions like severe bleeding and pregnancy-induced high blood pressure become treatable complications, not death sentences. Maternal deaths worldwide have fallen by nearly 50% since 1990, but in some areas, the death rates are still very high. In Guatemala, health workers are now using new kinds of training and outreach to save the lives of mothers and their babies.
Los caminos son un poco,
Welcome to Guatemala. The landscapes and the scenery is beautiful, but the roads are not so great.
Right now we're going to Raxuha. Raxuha is 7 hours away from Guatemala City.
My name is Solange Madriz, and I am with Global Health Sciences at the University of California, San Francisco.
5 years ago, there was no road. There was no asphalt road. So the road that we're right now is relatively new. Guatemala had a bloody civil war, and Raxuha was, if you will, a haven because it's so remote, it's so isolated that a lot of people feel that they've been abandoned by the government.
Now we're stuck in traffic. The reason for that is because there's a parade. It's a religious celebration of the life of San Martín de Porras. He was recognized because of his humbleness and also because of the love for the people.
In this area of Guatemala, northern Guatemala, the largest part of the population is Quechí, and they speak Quechí also as the name of their ethnicity. My name is Cristel Camposeco. I am the social marketing coordinator for CSR Guatemala. People here in Raxuha I find to be very warm-hearted, very hardworking, and very traditional in a sense. The women would usually stay at home while the fathers migrate to work the land. They are farmers. Most of them cultivate coffee, beans, and corn also, and the woman stays at home with the babies. Most families are very numerous. They have from 4 up to 7 children is very common, and usually the families start at a very young age. So we have marriages of girls at 16, and they start having babies at that age.
Guatemala is one of the countries in Latin America with the worst maternal mortality ratio, similar to some countries in Africa. Half of the maternal deaths in Guatemala are for postpartum hemorrhage. Postpartum hemorrhage means that a pregnant woman have a very flaccid uterus, sometimes because they have too many children, or other times it's because the placenta irritated and the placenta don't get delivery. Most of the women die in the first 2 hours. So this is why we need to move people to clinics to get the real attention to avoid that death.
Acción. Sí. Move. Move. Vamos a pasar a revisar. Okay.
Right now, we are in the clinic to reenact an emergency, an obstetric emergency.
Pronto is a simulation-based training program that we put together to improve the skills of providers who deliver babies in clinics.
Right now, we're preparing the simulation number 2.
Acción.
How to stop obstetric hemorrhage.
Our simulations occur in the same clinic where providers work, and that gives an opportunity to have a highly realistic scenario.
These are the parto pants. Inside she has a baby that she is going to push with her hands when she is instructed to do so. There's also a placenta. Here's the fake blood.
We use low-technology devices and only the resources that they have available in their own clinic. In Pronto trainings, providers learn communication and leadership skills that are as important as medical skills.
Our hope with these simulations is to prevent more women of this area from dying.
Hola, está con una paciente que ya va a dar luz. Aquí, allá en la comunidad. Se puede.
There's a birth. There's a birth in nearby.
We were here in the health facility when one of the nurses got a call from the traditional midwife in one of the communities and said she had a pregnant woman just about to deliver the baby. So actually, we asked if we could go pick her up.
No, porque por cualquier complicación del paciente.
Myrna is a nurse, and she's saying that they have a lot of experience taking the pregnant lady to the hospital or the baby being delivered here in the ambulance. So when I walked into her house, it was amazing. She was really about to have the baby. I could notice that she was in a lot of pain. We tried to ask her some questions about her situation, but she could not really speak. But luckily, there was her husband, Raul, who really talked us through the situation, said that she was in the last period of her pregnancy, so that she was just ready.
This is Aurelia, and she's 21 years old.
Aurelia was very satisfied to see the ambulance because she was feeling very exhausted and dizzy and thought that it was not also a good idea to deliver at home. So they decided to bring her here, the nearest health facility. Aurelia tells me that the reason why she liked this health facility was because the distance from where she lives from here is very short. It only took her 10 minutes to get here by ambulance. Her second child was delivered in a hospital, and she was not allowed to be there with the traditional birth attendant, nor her husband was allowed to be in the room. So they believed that this was a better treatment because they were allowed to be with her in that special moment in her life.
Hay dos.
Two babies.
Twins.
Dos.
Sí.
This woman is having twins. Right now we're with two of the midwives of the Que Vivan las Madres project, Anabel and Carolina. Guatemala is a country with a large number of indigenous people who still give birth at home with the help of traditional birth attendants or traditional midwives.
We are here in Lucia Cal's house. She is in the last weeks of her pregnancy, and luckily we have all the team here. We have a midwife from the program Que Vivan las Madres, and we also have a traditional midwife to help assist her for a quick consult in her house.
A traditional midwife is a midwife who hasn't received any formal training, but has received her skills from generation to generation.
¿Qué más hay que hacer? Mi nombre es Carolina Ren.
My name is Carolina Ren. I'm a professional midwife.
The traditional midwife was having some problem finding the baby's heart, but Caroline could explain to her, just try this, if you can imagine the baby's shape.
La parte más difícil de mi trabajo es
The most difficult part of my job is to achieve the link between the traditional midwife and the health system. That union, that's what's most difficult, because there are many traditions, a lot of culture involved in that. So it's like a paradigm that has to be broken.
They have very specific ways that they like to deliver their babies. For example, instead of the Western style of laying down in a bed and having your knees up, they would like to have it in the vertical way, just standing up and holding up by a rope or squatting. Our indigenous population also like that the traditional midwife is next to them, that they can have a drink, they can drink water, they can eat fruit, they can have, for example, after birth, they like to bury the placenta, and those are very specific ways and customs that they need to feel comfortable and safe. Sometimes when they come to the health facility, that's not respected. We just have the Western style idea, so sometimes they would rather risk themselves and stay at home, but follow their cultural ways. Our program here in Guatemala is called Que Vivan las Madres, which translates to Long Live the Mothers. And it has this name because what we're aiming for is to give life to the mothers, to prevent that they die during labor. My job is to open doors. That's how I like to think about it. I promote the program and we distribute our promotional material in the whole territory.
So right now, Carolina is showing the pregnant women pictures, graphic pictures, so they understand and see the importance of giving birth at the health facility.
We develop different type of workshops for women in the local communities.
todos los días.
Did you know that about 1,000 women die each day because of pregnancy complications?
Voy a dar 10. And we also have workshops with traditional midwives that work in the communities. We all have the same objective, to prevent women from dying and leaving their whole families in a very bad situation.
Proteja.
Our hope is that traditional birth attendants are going to refer pregnant women during labor to clinics. After delivering her first baby, the woman just learned that she was having twins.
Aquí no. Más. Aquí abajo. Magic hilang.
And as we can see now, this team of 4 people just successfully delivered her second baby. Los dos son niños. You just had 2 baby boys.
Lindo, felicidades.
For me personally, it was a very nerve-wracking situation because the woman was not only pregnant of 1 baby, but 2. And I knew it was a highly risky pregnancy. Even though I was nervous, I was happy to see that our own professional midwives were there to take care of the pregnant woman and the baby. At the same time, I was happy to see that the traditional birth attendant, the person who would have been taking care of the woman, was allowed to be in the room, as well as her husband and other family members. I was excited to see that the provider who was attending the birth was using the skills he had learned a month ago.
The concentration, the patience to act, to wait for the precise moment and then react with confidence. Now I'm going to have the pride of having delivered these 2 babies.
Okay, so this was a healthy, regular delivery.
Volver a revivir ese momento para mí fue muy importante.
Reliving that moment was very important to me. And as a woman, I felt proud to be assisting a woman in the birth of her 2 babies. I think that she felt the support that has not really been put into practice here. And that's what we are aiming for with the presence of professional midwives in each health facility.
The debriefs are the heart of the training program where all the learning occurs. During debriefs, participants watch the video and then as a group they identify the things that they did well and also the things that went wrong.
We have mothers dying during labor for preventable causes. So that's why we're trying to make these positive changes that are quite easy if we all work like a little clock. Everyone is contributing in their own part.
I would like to ask you, who of you would like to give birth in the health facility?
We're working to change behavior in this indigenous population. They have more than 500 years getting birth at home. Traditional birth attendants in Guatemala are necessary. They are really a good staff.
She's saying, oh my God, it looks like his dad.
We don't know what will be happening if they don't exist. The problem is when they have a complication during deliveries. We need to train people in health service, but also we need to work with community to come to the health service and get the deliveries. And this is the package.
The day after the delivery, we went back to the clinic to visit the mother and the twins. So here we have the professional nurse who attended the birth. He received pronto training last September, and he's doing a general checkup of the babies. The twins look healthy, and they're very vigorous, and they have beautiful colors. Her mom told me that they've been eating every 15 to 20 minutes. She's been active for the past hours feeding both babies. Because there were no complications, we were able to accompany the mother to her home, where there were a group of family and friends waiting for them to meet for the very first time the twins. Mira!
was a very emotional moment for me to come here with 2 newborns. And the fact that all the family were here and they were doing this ritual, the candles, and they were so friendly, and the things that they were saying, they were blessing the babies. Dos. And even though they were not my babies, because I was there when they were born, I felt very involved. It was very, very moving, and it went directly to my heart.
A tus bebés, muchas gracias. Y a ustedes les deseamos todo lo mejor. During moments like this ones is when all the work, all the planning, and all the obstacles that we face in Guatemala seems worthwhile.
Global Health Frontiers is made possible by support from the John Moores family. To find out more about this and other Global Health Frontiers programs, visit globalhealthfrontiers.org.